Alrighty, and we'll go ahead and get started. For this session, I'm going to focus almost entirely on the new content, as that is the biggest, heaviest portion of the exam as far as your final goes. If at the end you have questions on prior content, I'm happy to talk about anything. But for the sake of the review session, since I only have an hour with you guys, we're just going to focus on the three new things: cancer, HIV, AIDS, and bleeding disorders today. For some quick study tips per usual, please, please, please use the resources that your professors give you. They give them for a reason. They're meant to help. I cannot say explicitly because I don't know. I don't communicate with your professors about like the exams. But based on my personal experience, the blueprint has been super accurate in the sense that I don't typically study stuff that's not on the blueprint, and the exam mirrors the blueprint pretty well. Again, it is within the professor's right. I'm just disclaiming the professor can ask you questions that aren't on the blueprint, but from my personal experience, they do tend to mirror the blueprint. So definitely use that. When you study, make sure you break it down as much as possible. One class, one subject. I literally struggle with this every single final season. Literally today, I sat down at the library and I'm like flipping between my notes like ped, psych, public health, which one? And then I do 10 minutes of one and I think about something for psych, so I switch to another. That is not effective. I have learned the hard way. Sit down with a class and a topic in mind. Say, I'm going to sit down and study Unit 4, Patho 2 for the next 2 hours and nothing else. And that'll help you really just kind of lock in on a certain topic without your brain like just jumping everywhere, because that is an issue that I have repeatedly, especially with final season. And it's no surprise to you guys, finals are super, super stressful. So please, please, please prioritize yourself, your time, and your mental health. Move your body in whatever way that looks like for you. Spend time with people who are good for the soul. Get good food, get good sleep. Whatever you need to do, don't sacrifice yourself for the sake of finals. Obviously, put the work in, but you come first. Alrighty, so we're going to get started with the cancer material. Per usual, at any point, if you have any questions, please, please, please feel free to interrupt me or put something in the chat. And then we're going to do the same structure where it's a little bit of content review and then some practice questions for you. Here are some quick terms to know. Again, I don't typically go over these, but I would be familiar because chances are these are going to be used within questions on the final. Yes. Oh, sorry, I should have said that. If you missed the sign-in link at the beginning, I have it at the end as well. So I'll end with that, and then you can sign in and do all that stuff. Thank you for asking. I should have said that. Okay, so for the pathophysiology of cancer, you have normal cells and you have malignant or cancerous cells. Normal cells are well differentiated in appearance and function, and they reproduce for a purpose and stop when that need is met. So there are a lot of mechanisms that your body has to regulate that reproduction, and in a healthy person, that all those mechanisms are intact. With malignant cells, however, these are undifferentiated and uncontrolled. They have no purpose, no functioning purpose for your body. They steal and consume nutrients from your normal healthy tissue, and they do have the ability to break off and invade tissues or circulate via bloodstream or lymphatics. Similarly, benign tumors are non-cancerous tumors, and the cells there resemble those normal cells. They can be well differentiated and they're localized. They don't spread. When someone does a biopsy and they find out their tumor is benign, that's always good news. Whereas malignant tumors, these are cancerous tumors, and the cells then resemble malignant cells, so they're not normal, and it does have the capacity to spread and invade surrounding tissue. Carcinogenesis is the process of normal cells becoming cancerous. This happens in anyone who develops cancer. There are three main processes to know. There's initiation, which is when the carcinogen causes a cellular change in like the cell and the cell's DNA. So that's like that exposure to whatever your carcinogen is, say it's asbestos, changing that cellular DNA. Promotion is when those cellularly, like DNA altered cells begin replicating and expanding. So now you have abnormal cells proliferating. And that's encouraged by repeated exposure. So if someone is coming into contact with the same carcinogen time and time again, that encourages the process of promotion. And then third, there's progression. This is that increased malignant behavior There's also a process called angiogenesis, so let's just say blood vessels, I'm sorry, new blood vessels form to feed these malignant cancerous cells. So at the point of progression, your things are pretty far progressed as far as the cells transforming from normal to malignant goes. Carcinogens, we all hear about them everywhere. Some states have like requirements where if there's a carcinogen, you have to label it. And it's like everything is a carcinogen in this day and age. But they can be classified into viruses and bacteria, physical agents like radiation, chemical agents like pesticides, tobacco, genetics and family history. Some cancers truly just are genetic. Lifestyle, obesity, and poor diet are linked to cancers, and then hormonal agents as well. Prevention, you're going to see the same important primary, secondary, and tertiary prevention that we see kind of across the board. So there are examples there of what those look like. Clinical manifestations of cancer are super, super variable. I mean, there are dozens of types of cancers, and depending on where the cancer is and how far along the cancer is, that will impact how your symptoms present. But some general sorry, I need to take a breath. Clinical manifestations would be weight loss, anorexia, cachexia, poor healing, altered organ function, anemia, pain, immunosuppression. These are just some clinical manifestations that can occur most commonly, I would say, or with multiple different types of cancers. But symptoms are just going to be super variable. In treatment, your goals are cure, control, or palliation. Cure is exactly what it sounds like. It's the eradication of disease. Control is the goal is prolonging survival. Maybe you know that eventually this cancer will kill you, but we're going to try to control it to prolong your life. And then palliation, the goal is relieving your symptoms and promoting your quality of life. This is seen a lot in terminal cancers where kind of the cons of attempting things like chemo and radiation outweigh those benefits. And you just work on pain management and comfort until the patient eventually dies. There are different types of surgeries to know. There's diagnostic, which is that biopsy. Treatment, which is like typically removal of the tumor or like the surrounding lymph nodes that could cause metastasis. Salvage surgery, which is more primarily to treat recurrence. Prophylactic surgery, this is when maybe someone's entire family has a history of ovarian cancer, so they decide to get their ovaries removed before they have any malignant activity, just as a preventative measure. And then there's reconstructive surgery that can be done to perform or to improve function or aesthetic cosmetics. Like if someone has a double mastectomy because of breast cancer, you can get reconstructive surgery to like give yourself back breasts and those types of things. Also, I am going through this kind of quickly because I know you cover most of it in adult and we have a lot of content to cover. So if I need to slow down, just yell at me and then I'll slow down. Radiation therapy can be curative. Its goal is to reduce tumor size, often prior to surgical removal. But it can also be used for control purposes or palliative purposes. The cells that divide the most frequently are the most susceptible to radiation in general. So if you have rapidly dividing cancer tumor cells, that is when they'll be the most effective with radiation. External radiation is the most common type. And then there is internal therapy like brachytherapy, which is the placement of those radioactive beads often within or next to the cancer site. I think in adult too, you talk about prostate cancer, like the beads that go in there. That's brachytherapy. Adverse effects are typically localized to the area being treated because radiation is super specific. So you can have acute toxicities, radiodermatitis, which is like skin breakdown and irritation, and bone marrow suppression. And then you can have systemic effects like fatigue, malaise, and anorexia as well. If a patient is receiving brachytherapy, meaning they actively have radioactive material inside of them, they need to be in a private room. Visitors are super limited, especially if you have any pregnant visitors. And then the goal is to maintain 6 feet of distance as well to prevent any radioactive effects on like the healthcare team or visitors. Chemotherapy then works to kill cells by interfering with their replication in different stages. They are most effective against rapidly dividing cells, regardless of their status as normal or malignant, which is why people on chemotherapy lose their hair because hair cells like follicles are rapidly dividing. So chemotherapy will attack those as well. Typically, repeated doses are required to kill all cells because each dose of chemotherapy will only kill a specific number of the cancer cells. And it's often administered in combination to reach maximum effectiveness and also to minimize damage to those healthy cells. So it's administered in a cyclical nature with recovery time so that the body can replace killed normal healthy cells in between. Complications, the main one is immunosuppression. Almost every patient on chemotherapy will be at a high risk for things like infection, bleeding, um, as listed by like the neutropenia, anemia, etc. And then nausea, vomiting, mucositis, bleeding, and fatigue. Chemotherapy is not a fun thing for the patient. There are a lot of physical side effects that often cause a lot of emotional and mental side effects as well. So treating a patient going through chemotherapy is super multifaceted and requires a lot of just like awareness and therapeutic communication. Okay, here's the first practice question. What is an example of secondary cancer prevention? Yeah, you're right. That one is D. Um, A and B are primary, C is tertiary, D is secondary, because mammograms are part of the screening process. Which of the following statements is not true about radiation? Perfect. Yeah, that one is C. Typically across the board, they teach us in nursing school, if something says always, it's almost always not true. There are almost always special occasions. But for this sake, radiation can be curative or for control or for palliation. Which of the following is an example of prophylactic surgery? Awesome. Yep, you guys are correct. That one is C. That's that prophylactic, almost preventative surgery. If you remove both your breasts, you have a much lower risk of developing breast cancer. So, moving on to more the pharmacology side of things, it is important to know these four phases of the cell cycle, the S phase, G2, or sorry, G1, G2 and mitosis. Just because you need to know where the different agents of medication would work. So just be familiar as to what those phases are in general. Um, the first category for cancer drugs is alkylating agents. These include your cyclophosphamide, your nitrosoureas, platinum agents, and triazine compounds. I really took the most key information about each one for this PowerPoint. Um, Really important thing about the alkylating agents, they are cell cycle non-specific, so they work in all the phases. The prototype is that cyclophosphamide. It's the most commonly used. An adverse effect to know for sure is hemorrhagic cystitis. Symptoms would include hematuria and urosepsis, and you would try to prevent it with increased fluid intake. So that's characteristic of cyclophosphamide. Carmustine and lomustine are alkylating agents that are highly lipid soluble, meaning that they can cross the blood-brain barrier with the cerebral spinal fluid and work in the brain. So those two medications are highly effective for like brain cancers, spinal cord cancers, et cetera, because they can cross that barrier. Carboplatin is the platinum agent prototype, and dacarbazine is the most commonly used triazine compound. The next category is anti-tumor antibiotics. These are also active in all parts of the cell cycle, and they have a similar like action and effect as alkylating agents. The two most important things to know for this is going to be their toxicity effects. Daunorubicin has a risk for cardiac and bone marrow toxicities, and bleomycin has a risk for pulmonary toxicity. When I studied this last spring, yeah, my friend remembered bleomycin with pulmonary toxicity because it sounded like bleh, like coughing up, like sputum, like bleh. So bleomycin and pulmonary toxicity, that was how they remembered that one. Antimetabolites are a medication class that work in the S phase. The main one here is methotrexate. This is a folate antagonist, and this works because folate is a nutrient, a compound required for cellular division as well as DNA synthesis. So if you inhibit folate, you inhibit division and synthesis of those cancer cells. And then fluorouracil, this is a part that it is a drug that incorporates itself into RNA, halting or changing cellular growth. I don't know how much you guys remember from microbiome, but uracil is part of RNA. So this is like fake uracil, like it implements itself into the RNA to change that genetic makeup of a cancerous cell. Then you have plant alkaloids. These are primarily taxanes and vinca alkaloids. The taxanes work in G2 and M phases, and allergic reactions are super common. So oftentimes you're gonna pre-medicate for taxanes with like Benadryl, stuff to prevent those hypersensitivity reactions. Vinca alkaloids, the prototype is vincristine sulfate. The adverse effect here is neuropathy, and then the overdose of vincristine sulfate can cause paralysis. So I think those two go hand in hand, neuropathy progressing into paralysis. Cytoprotectants, then, these are not chemotherapy agents. These are not cancer drugs. These two are drugs that work to reduce the adverse effects of those cancer drugs that we talked about that are used in chemo. So there's these also we talked about in the anemia unit as well. So there's epoetin alpha to treat anemia and stimulate red blood cell production, and filgrastim to treat neutropenia and stimulate that neutrophil production. What part of the cell cycle do alkylating agents work in? Perfect. Yeah, you guys are right. That one is cell cycle nonspecific. What is an adverse effect of the anti-tumor antibiotic bleomycin? That one is pulmonary toxicity. And then A and C are those adverse effects or risks of daunorubicin. Which part of the cell cycle do antimetabolites work in? These are kind of hard. If I didn't study these before, I'm not sure that I would remember. So no stress. This one is going to be B as well. This is S for the antimetabolites. Your patient is receiving cyclophosphamide for cancer treatment while admitted. Which of the following findings is the most concerning regarding this medication? This one is going to be A. I talked about the major adverse effect of cyclophosphamide is hemorrhagic cystitis. So blood in the urine, that hematuria is going to be the most concerning sign. B, C, and D are pretty much, they're expected with chemotherapy. So that wouldn't be like concerning findings pretty much. Alrighty, that was everything for cancer, and we're making really good time. So this is HIV and AIDS, again, pathophys and pharmacology here. Terms to know, just be familiar with like viruses versus retroviruses, because HIV is a retrovirus. And then just some of those acronyms, which we will talk about, ART, PrEP, and PEP, functions of T cells, CD4 receptors, etc. So for HIV, the virus is a retrovirus, meaning it carries its gene material in its RNA. The virus targets healthy CD4 receptors on T cells, and it can progress. HIV is a virus that can progress to AIDS, which is a syndrome of acquired immunodeficiency. It's characterized by the progressive immune system impairment due to destruction of T cells. And HIV is transmitted via bodily fluids like semen, amniotic fluid, blood, anything like that. It is classified into stages 0 through 3. Stage 0 is where the viral load is high, you're contagious, you have HIV, and you're really just kind of showing minor signs and symptoms of a viral illness. Stage 1 is the viral set point, so you reach equilibrium between HIV and their immune response. And at this point, the patient might feel pretty like normal, maybe lingering symptoms. Stage 2, the T cell count drops. This is from that attack on your CD4 receptors on the T cells. And stage 3 is the development of AIDS, which puts you at a very high risk for opportunistic infections. ART is the shorthand for antiretroviral therapy, and just terminology-wise, it's a retrovirus. So ART is just treatment against a retrovirus. So it's concurrent treatment with multiple drugs from different classes, and it won't ever be curative. The goal is to reduce the viral load to essentially zero, like as close to zero as possible, but they're just not curative. Different classes reduce the risk of resistance. That's kind of why they go at it with a multi-angle approach. The benefits, it can allow a patient to live symptom-free. Again, that viral load is super, super low. Reduce transmission from mom to baby, better prevention overall, and it's proven that there's a steady decline in the death rate from HIV and AIDS. Adverse effects here, you're looking at liver, kidney, and cardiovascular toxicity diseases. The thing with ART that makes it really difficult is it depends on client adherence. Client adherence with antiretrovirals is difficult because they're on an inconvenient schedule. You take them for a long time, and they have adverse effects that just aren't fun for a patient to go through. Um, and a lot of the times, your patients with HIV might not have the best resources or the health literacy to be able to want to or have access to the medication that they need at the schedule they need it at. To evaluate effectiveness, you're going to monitor the patient's CD4 count every 3 to 12 months. And then education point is that stopping ART would result in rapid rebound HIV replication. So things can get pretty bad pretty quick if you stop taking this therapy. PrEP is pre-exposure prophylaxis. I see commercials for PrEP all the time, like on Netflix and Hulu and stuff. These are antivirals taken by those who are at a high risk to prevent infection of HIV. So this is not, the person does not have HIV if they are taking PrEP. They are just at a higher risk. So they would engage in pre-exposure prophylaxis. PEP then is post-exposure prophylaxis. This is most commonly following an occupational injury. In our lovely profession of nursing, needle sticks are an injury that could occur and could put you at risk for HIV. So the guideline from the CDC is starting treatment with more than 3 antiviral medications within 72 hours of exposure. And I listed some of the antivirals that are there for you. But yeah, that is unfortunately important to know because it could apply to any one of us at any point in our career. Mother-baby treatment, the goal here is to lower the mother's viral load and in turn protect the newborn. If the mother is HIV positive, you want to start the ART as early in pregnancy as possible. And then during labor, you would run a continuous infusion of zidovudine because that crosses the placenta and provides protection to the newborn or fetus at that point. If the mother is treated during pregnancy, as in she's seeing providers, she's in ART, etc., the newborn would be treated with 4 weeks of prophylactic therapy with just one drug, zidovudine, after birth. And if they're not treated during pregnancy, as in they either didn't know they had it or they didn't take prescribed medication, the newborn would be treated with 6 weeks of prophylactic therapy with multiple different drugs. And then by about 1 to 2 months of age, if the infant had HIV, we would know at that point. NNRTs are a class of antiretroviral medication. The prototype is efavirenz. This one just prevents, its action is preventing the process of reverse transcriptase. So it just halts that replication process of the virus. Adverse effects, main one with this one is liver toxicity. but can also affect your CNS. And then NRTIs are similar. You often see like NRTIs and NRTs grouped together. The prototype here is zidovudine. This is the one we talked about for mother-baby situations. This terminates viral replication. Main adverse effects to know here: liver toxicity, blood disorders, bone marrow suppression, and lactic acidosis. So you can see why adhering to these types of medications would be difficult, because they put you at risk for a lot of different things, and symptoms of those would not be enjoyable. Protease inhibitors, these block protease, which is an enzyme responsible for the formation of virions. Again, just inhibiting part of that viral replication. The prototype here is sequinavir mesylate, and adverse effects are cardiac arrhythmias, CNS abnormalities, pancytopenia, and liver issues. So again, extensive list of adverse effects. The integral strand inhibitors are used in combination with NRTIs. The prototype is raltegravir, and these are beneficial because they have fewer adverse effects. It's kind of a bummer because they're used in combination with a drug that does have adverse effects, but to be the most effective, you have to combine them in that sense. So what does HIV target? That one is A. What is the treatment regimen for a newborn baby whose mother is HIV positive and did not receive treatment during pregnancy? Also, I realize I'm saying those should all say of, not or. I don't know if you were here at the beginning, but I was saying I switched to Canva, and Canva does not like identify any typos like Google Slides did. So there are more typos than I would like. So I apologize. This one is going to be, let me see, C. So this is a mother who is HIV positive and did not receive any prophylactic treatment during pregnancy. So that's the most extensive treatment we offer newborns is the 6 weeks with multiple drugs. When would someone follow PEP protocol? Okay, this one is D. A would be PrEP, B and C would be just antiretroviral therapy, but D is that PEP protocol, that post-exposure. Alrighty, so that is HIV, AIDS, and medications. The third topic we have today is bleeding disorders and anticoagulants. Terms to know here, you have hemostasis, that process we've talked about in the past, and then the difference between an anticoagulant versus an antiplatelet. Functions, there are just some parts that mainly play a role in hemostasis that are just important to know to understand the broader concept of the disorders. You've got platelets, plasmin, fibrinogen, vitamin K, factor 10, etc. So thrombocytopenia is in general a low platelet count. That ending penia is always like low something, and thrombo is platelet. This is caused by one of three things: decreased platelet production in the bone marrow, increased destruction of platelets once they're circulating in your body, or increased consumption of the platelets. Clinical manifestations of thrombocytopenia are bleeding. That is most commonly seen with bleeding gums or like excess bleeding from wounds. In women, they can have heavier periods because of this. You can also see petechiae, which are, we've talked about them before, I think, but they're like tiny, tiny bump, like not bumps, like red spots under your skin from vessels and capillaries bursting, if that makes sense. Treatment here for thrombocytopenia is to treat the underlying disease and to stop and prevent bleeding, just to prevent blood loss. Immune thrombocytia, I need to stop. Thrombocytopenia purpura. This is when the specific antiplatelet antibodies bind to platelets, and mark for destruction by the immune system. So this is like the autoimmune destruction of platelets by specific antibodies. So this is an autoimmune condition. A patient with ITP might be asymptomatic depending on the severity and then whether it's dry or wet. Meaning dry ITP typically is less severe, the patient has better outcomes, and their symptoms are pretty limited to bruising and petechiae, maybe more excessive bleeding with menstrual cycles or wounds, but that's less severe. And then wet ITP puts you at a higher risk for like GI tract bleeding and life-threatening bleeding in general. So that one is more severe with poorer outcomes. The diagnosis here would be pretty much exclude other causes. To some degree, there are going to be like immunologic testing that can be done, but it is most commonly a diagnosis of exclusion. Treatment is going to be based on the severity of bleeding as far as like treating bleeding and what you do with the condition. So something super important with ITP is that a platelet transfusion is not recommended here. In someone who is going through chemotherapy and has pancytopenia as a side effect, sure, give them a platelet transfusion. Chances are they need it and that would help them. Um, but with ITP, if you give them an infusion of platelets, a transfusion of platelets, they're still going to destroy them. Like you have those antiplatelet antibodies that will bind to them and mark them for destruction regardless. So there's not much of a benefit there in a platelet transfusion with ITP. Platelet defects, these are different from thrombocytopenia because the platelet count isn't typically low. It's like often a normal count, but the platelets themselves are not functioning correctly or how they should be. A lot of causes here are actually medications, like aspirin, because aspirin reduces platelet aggregation, and this has an effect that can last up to 7 to 10 days. So even if you stop taking it, you can have that reduced platelet aggregation for up to 10 days after. And then NSAIDs like ibuprofen have a similar effect as aspirin, but the effect is only 4 days. Also, certain chronic diseases can impact your platelet function. With anything platelets, the clinical manifestation that we look at is bleeding. So treatment here is to stop that contributing medication like aspirin or NSAIDs or a platelet transfusion. This is an instance where that could be helpful. Education, if they're at a higher risk for this or using medications like NSAIDs excessively, you would teach about those medications that could contribute to excess bleeding and knowing when to stop those to reduce like undesired bleeding type of thing. So hemophilia A, the one we talk about here, it's a genetic defect in factor VIII. It is more common than hemophilia B. Um, Factor VIII is a clotting factor, so again, we're talking about bleeding. So the treatment here is recombinant factor VIII concentrates that are typically given during active bleeding. So this is just like artificial factor VIII in a sense, if that makes sense, or like donor factor VIII to replace that genetic defect or lack of in patients with this. Patients, however, can develop antibodies to the concentrate treatments. So therefore, you can also give steroids to control those antibodies because in someone who has hemophilia A, you need your medication to be effective. So you could give steroids alongside to prevent tolerance or the autoimmune destruction of the recombinant factor VIII, if that makes sense. Von Willebrand disease, this is the genetic deficiency in another factor. This is specifically needed for factor VIII activation. So similar effect across hemophilia A and von Willebrand disease. This is actually the most common inherited bleeding disorder. And specifically, this one is characterized by bleeding in mucous membranes. And treatment is that von Willebrand factor or factor VIII when bleeding occurs or prophylactically before a procedure. So knowing just like hemophilia and von Willebrand as being genetic, you have those replacement factors typically given during active bleeding or maybe prophylactically during a procedure. Those would be important things to remember here. Disseminated intravascular coagulation. If I'm going to be so honest, this confused me so bad when I was in the class. I was like, how are we clotting and bleeding all at the same time and it's causing this much of an issue? I truly couldn't like wrap my brain around this. So I did find a video on YouTube that does a good job at explaining the pathophysiology here if you're more of like a visual learner versus, like just hearing me talk about it. But DIC is an inflammatory process generated by an underlying disease like infection, sepsis, trauma, cancer, or shock. So all at once, you have excessive blood clotting, the dissolution of clots, and bleeding going on. This can affect multiple organs all at the same time, which is partially why it is so life-threatening. Um, Lab-wise, for diagnostics, you're looking at a progressive drop in platelet count as they're being used up for clotting, and then a prolonged PT, APTT, and thrombin. Those will be the characteristic lab values for someone experiencing DIC. Clinical manifestations, you're looking at, again, that progressive drop in platelet count. As clots develop, these could be impairing your organs. So you have signs and symptoms of organ dysfunction across the board. I mean, this can really cause like multiple organ failure. Um, as the clotting factors are used up, then you can also have excessive internal bleeding as well. Treatment here, I almost like hate when the treatment is treat underlying disease because I'm like, I don't know what that means, but it is. It's to treat that underlying disease. So in this case, shock, sepsis, infection, whatever the case might be, that's your priority. And you can also give heparin to interrupt clot formation, and that will help protect organ function in this case. Practice question. True or false? Immune thrombocytopenia purpura can be treated with platelet infusions. Awesome. Yes. Thank you guys. This one is false. That one is the autoimmune one. So there's really no point in transfusing platelets because they're just still going to get destroyed by the body's immune system. Alrighty. So heparin, this is an anticoagulant. It is the traditional drug of choice when it comes to pharmacology for this. It works by inhibiting clotting factors, therefore inhibiting coagulation. Typically used to prevent further clot formation in patients who have like a diagnosed or suspected DVT or PE, so the deep vein thrombosis or pulmonary embolisms. It is the drug of choice during pregnancy. It's the safest for a pregnant mom. The number one adverse effect is bleeding. I mean, you're, preventing your body's ability to clot. So the risk is bleeding. So this, if someone's on heparin, it's like you want to be mindful of things that could cause excessive bleeding because the body's not going to be able to clot like it should. APTT is the lab value used to regulate dosing for heparin. As far as these medications goes, definitely know how dosing is regulated, so the APTT would be good to know, and then antidotes. Um, Again, these all can cause bleeding that can be life-threatening. So the antidote here for heparin is protamine sulfate. Definitely know that going into your final. LMWH is low molecular weight heparin. It's a synthetic heparin that has the same anticoagulant effect as heparin. It's enoxaparin. I've given it in clinical, I'm sure some of you have. While similar to heparin, it's not interchangeable with heparin, so it can't just be like one day I'm on heparin, but I took enoxaparin the next day. Like that's not how that one works. It's less likely to cause thrombocytopenia, and it's the drug of choice for DVT post-op prevention. I think you learn about it a lot in adult too, but you're at a high risk for DVTs post-op, so they could give you something like enoxaparin during that post-op period to prevent a DVT from developing. Again, we want to know those lab values and antidotes here. So the vitamin K antagonist is warfarin. Warfarin works by inhibiting vitamin K, which in turn suppresses the creation of clotting factors by the liver because vitamin K is needed for that. Warfarin has drug interactions with aspirin and NSAIDs, so you would have to check medication history um, and confirm that they're not on those medications actively. Adverse effect here again is bleeding. Warfarin has a narrow therapeutic window for benefits without the effect of bleeding. So that's why this one is like kind of very closely regulated. You would monitor the PT or INR lab values every 2 to 4 weeks if the patient is stable, but if they're unstable and more in like critical care, you would do that a lot more often. And the antidote here is vitamin K. So the drug is a vitamin K antagonist, antidote is vitamin K. They tend to go hand in hand. Alrighty, factor XA inhibitor. The prototype here is rivaroxaban and also apixaban. They have the same ending there, XABAN. It's an alternative to warfarin just because warfarin does have that like narrow therapeutic window. This is an option that doesn't require monitoring like warfarin would. It also blocks factor XA and inhibits thrombin production, platelet aggregation, and fibrin formation, so those clots. And the antidote is indexanet alpha. Something I use to remember this one is all the X's. Factor XA inhibitor, rivaroxaban, and indexanet alpha. So there's a lot of X's that show up that you don't see too often in other places. Aspirin is an antiplatelet that inhibits platelet aggregation. Important to know that the effect may last for up to a week after one dose. Aspirin can be toxic, it can reach toxic levels. Um, Early signs of that are tinnitus and hyperventilation. So if your patient complains of ringing in the ears, there's a chance they're reaching aspirin toxicity. ADP blocker, this is clopidogrel. We talk about this a little bit. I think we talk about it in Patho 1, but it's another antiplatelet that alters the actual membrane of the platelets so they can't recognize signals to aggregate like they would normally. With clopidogrel and ADP blockers, the most important thing to remember is that you need to discontinue the drug 5 days before any dental or medical procedure, and this is just for bleeding precautions. A thrombolytic, the preferred one is tenecteplase. This works to destroy clots. We talk about this, I think, again in Patho 1 with the strokes. It's used once a clot is confirmed. So you're talking like confirmed heart attack, pulmonary embolism, DVT, stroke, those types of things. It works by breaking the clot down to restore blood flow to the area that was blocked off. It's like goal there in restoring blood flow, you're limiting organ damage. So hopefully, like if someone has a stroke, you administer tenecteplase, the effects and damage to the brain is hopefully less than it would have been otherwise. Tenecteplase needs to be administered within 4 hours of the clot formation to be most effective. And that can be kind of difficult because if your patient is experiencing a stroke, for example, there's no way to pinpoint exactly when that clot formed. Um, you're not just going to know, oh, I felt it form at this time. So really just administering it as soon as possible, but within 4 hours if possible. It also has a narrow safety margin. So you need to stop the infusion if the patient starts having signs of bleeding. You don't want to overcorrect a problem and just create more problems. So like the others, adverse effect here is bleeding and hemorrhaging. It can also cause cardiac arrhythmias. The antidote for tenecteplase is aminocaproic acid. I would know that. And if bleeding in excess occurs, you want to stop that infusion. Like I said, there's that narrow safety margin. So knowing that your patient is on tenecteplase, high risk of bleeding, having that antidote, being aware of it, and having it ready would be important here. What is the antidote for heparin? This one is going to be C, ammonium sulfate. Yes, thank you. Um, I can go back for a second. A is for warfarin, B is for that tenecteplase, and D is for Tylenol. So we're not even talking about that. But yeah, C is correct. Which is, or what of the following is mainly used to regulate heparin dosing? Yes, you are correct. That one is D. What is the antidote for warfarin? Perfect. That one is A, vitamin K. That's the vitamin K antagonist. So vitamin K works as the antidote. When is tenecteplase most effective? Yes, that one is C. Perfect. I'm going to pull this back up. Because it is the final, I want to offer room for any questions. We have 10 minutes left. If anyone wants to talk about anything from the course, I would be happy to try to help. Otherwise, feel free to put your email in the chat and I will send this PowerPoint to you tonight. And you are free to go if you signed in on that form for me. You guys are all going to do great. Good luck on your exam. Please, please, please don't hesitate to reach out if you have any more questions or need assistance during your study. I'm going to stop recording though.